End of Life Doula, take 3.
Hi, I'm Laurel Marr.
I'm Kate Daniels.
We are here to facilitate a conversation on how end-of-life care doulas and hospice teams can work together. Kate and I recently worked on a dynamic case together here in Virginia where we live, and thought it would be beneficial to get together and talk a little bit more about it and show those interested in training to be end-of-life doulas the importance of their call, and educate those who are considering hiring an end-of-life doula to see how the hospice team and the doulas can work together for a positive impact at the end of life.
Many people don't understand the benefits of hospice, when it can be utilized, what it includes, how it's accessed. And I think there's just a lot of misinformation out there. And this is a really good test case to talk about because we had a lot of interaction together as we worked with this gentleman.
Yes, yes. And I when I talk to families sometimes and they say they were disenchanted with hospice, I believe what's really going on when I dig in a little deeper in the conversation is that they expect there's going to be a lot more time with the hospice team. So that is something that's really important for end-of-life doulas to understand well, and to help their families remember that hospice is an invaluable support. What we are confused about is how much time we're actually going to have with the hospice team. So let's talk about this case. Kate and I actually didn't meet on the case. We met in a beautiful setting and at a networking event. We were introduced by another man who works with seniors and helps them organize their care as they age. And so Kate and I met and immediately were gravitated towards one another. We're both Christians, and said, well, it would be great to work together one day. And not too long after that, I took a case with a Christian in the community where I live, and said, I know someone who would be a great person to draw in and get you into the right hospice program. And so our work together started there. But I want to give a little history on this case first. And this was a man who was 60 years old, had a terminal diagnosis with a year and a half left to live. And he did every treatment possible, even waited for a clinical trial. Actually, the door opened for that, and he went to his first clinical trial engagement and was actually turned away because his hemoglobin levels were too low. And then he ended up having complications from his cancer. He was no longer receiving treatment, and that's why he was put into a trial. And so just the way that things went with the progression of his disease, he was no longer eligible for the trial, and then instead of being referred to hospice, he made the choice to wait for another trial to open. That did not happen, and it was soon apparent that hospice was the only choice for him if he was going to have the highest quality of life at the end of his life. So he did take his doctor's suggestion and go to a hospice. But I said to him, hey, before you really get started, I want you to consider working with this particular hospice. I'm connected with their care coordinator, and so our journey began together.
Mm-hmm. I think it's interesting also to point out what you had said to me regarding this case, that the care was really delayed by the professionals in the doctor, oncology office setting, putting unreasonable expectations out there for him. I think that was another thing that maybe we wish could have been different, accessing the care earlier.
Exactly, because I spoke with you and we came in, we all met together
months prior
the beginning of his trial.
Yeah.
And what really would have been beneficial is that if he did have the opportunity to engage in that trial, but also receive the benefits of hospice.
Mm-hmm.
Because a trial is no promise that there is going to be an improvement in one's condition.
Right.
And so, but because of insurance regulations. He was not on Medicare yet, but even with his the circumstances with his insurance, that he could not do both. And so he had to forego the benefit of hospice care to wait for a trial that really never worked out for him. And he could have been receiving the hospice care. Instead, one night he woke up in the middle of the night and went to the emergency room on his own. And so it's very difficult to navigate end of life care when you have a terminal illness, when you don't have the support of hospice.
And that's, I think, something I want to address as a bigger picture topic, maybe for another podcast, when to access those services, and certainly how early you could potentially access hospice. You don't have to wait until you're in your final month of life, which is really what we ended up having with him. And it just really put everyone at a bit of a disadvantage to try to help him rush to the finish line. And that was a sad situation, but hospice can be accessed when you have that terminal diagnosis and a life expectancy of 6 months or less. Typically, oncologists tend to overestimate how much time you have left, and that can be tricky to a family and a patient trying to understand what's next for them from a medical standpoint, which is really where hospice comes in. Hospice is a medical treatment plan. It's a philosophy of care that focuses on comfort rather than cure, but you have to be really ready for that acceptance level and not be wanting to take a clinical trial and potentially extend your life. So that was where he was between a rock and a hard place.
Right. Well, and I do think that, when I had conversations with him about his faith and his expectation of what, the end of life meant for his life, he kept saying to me, I'm not afraid to die. I don't want to die. And so those are two very different things. And certainly when he received the hospice referral and made the decision, he made it rather quickly. What was more difficult was which hospice agency he wanted to go with. But once he received that referral, things just shifted, and he was emotionally prepared to face the end of his life where he wasn't prior to that diagnosis. Once there was hope, however faint it was, that was the choice that he wanted. And so I think that that is always going to be a difficult piece for people, is when do I maybe what they feel like is they're giving up, or when do I make that choice that I'm succumbing versus.
Well, it's a shift in thinking. And it can be that hope looks different. Hope for a peaceful passing, hope for a comfortable passing. It's different than hoping I'm going to get better and I'm going to walk again. And I don't want to take hope away from anyone, but it's just trying to manage a little bit of that shift from a philosophical standpoint, emotional standpoint, and a spiritual standpoint, and in our world, a Christian standpoint.
That's it exactly. And even with his conversations with his physician, he liked his physician very much. But with the little bit of hope that was out there that perhaps this trial would be the thing that made him well, or even extended his life for 6 months, my client didn't want to complete his planning. And so, really, we need help from the physicians, right, to encourage people to get into hospice at a good time, because it's going to make a big difference for everybody. But I want to go to what to expect with hospice care once someone takes that referral that comes from their physician. And one of the things that I think was awesome about working together was you turned it around really fast. You had him admitted into your hospice very, very quickly, and it seemed very simple. And that is something cumbersome is not what families need, right? So working with hospice, my experience, it was very good.
Glad to hear that. I think part of the job that I have done for 14 years, bringing people onto services, I do the legwork, I get the paperwork started, get all the clinicals from the physician, any kind of background things, do an intake session, and then get it ready for the nurse to admit the patient. And really from there, that's where the handoff is. But with this particular case, and with a lot of my cases over the years, I stayed a little bit more available to help behind the scenes as a liaison, to connect all the parts and pieces, because again, in this case, there were a lot of parts and pieces with different POAs and different points of contact. This gentleman, again, as a case study, was unique in the fact that he did not have a family, he did not have any kids, any relatives. His friends were his family, which is a wonderful thing to have. Thank goodness he did. But it was great that he also had you to act in that stead, to kind of help coordinate those disparate pieces.
Yes.
And then I was able to kind of liaison between that and make sure that you had access, which was another thing to bring up.
Yes, I want to hit that. But I think, in this case, because there was a delay and because there was, an emotional hang up around, letting go of the potential of a trial, right? That the organization behind the scenes, really needed to be smooth, and we were able to do that. And one of his, one thing that was hard for him was he had been through hospice care with his mother, and so he had his own discomfort with his experience with hospice, because when his mom died, I think that they had one visit, and that was afraid. He was afraid. One visit in those last few days, right?
Yeah.
He wanted more support than that.
Right.
And so, he kind of went in with this mindset that, well, I don't know why why don't I just push to the end and just die alone versus, give up my availability to enter into a trial and then have a service that I'm not going to be completely happy with, right? And so, that was really, really difficult for him. But once Chris was enrolled, I really was surprised to find that, you and I had been able to talk, about his case prior to his enrollment, and then he got enrolled. And because he didn't have family, I began, continued to be that liaison, but there were some steps that he had to take in hospice so I could continue to be the point person on his case.
Right.
And so let's talk about that a little bit.
Yeah. So sliding back to the frequency and what to expect also, I think I can marry these two. The frequency of visits is really regulated by Medicare and the nursing staff that you have, whatever hospice you go with, what their staffing model is, what's their protocol. All of it is highly regulated under Medicare, and I think that was something he also was very wary of, because it has restrictions, what you can and can't do, how long your visits can be, how frequent your visits can be. All the disciplines can come out, but if someone declines chaplain services, for example, or someone declines having a social worker, that's within their right to do so under the hospice program, but then you don't see as robust of, staff coming out. You don't have as frequent visitors if you decline some of those services. So people don't understand that. And then I think the other piece that's hard for folks is they think that they're going to have a caregiver. And there is not a caregiver under hospice. It is not anything Medicare is going to pay for, which I could do another whole seminar on what Medicare will pay for. And they don't pay for people to sit with you. Under Medicaid, you could find that potentially, but not under Medicare. So most people that come out into retirement with just Medicare think they're going to be taken care of, and that just doesn't happen. So that's another reason it's so important to be able to understand and navigate what resources are available under your insurance and what are going to be private pay, and how to potentially fund that gap. Twice a week nurse visits, twice a week aide visits. Maybe you've declined social workers and chaplains as part of your care team. You're going to see somebody maybe every couple of days for about an hour. And that is really it. You have a 24-hour phone number that if you have an emergency, they can come out. But again, they don't all live right around your house, and they'll be coming from a distance. Sometimes they'll be attending someone else or attending a death, and there may be a delay in care. But that is how Medicare drives the hospice industry in general to running their organization, so that they can also make their ends meet under the hospice benefit. They pay a daily rate, and the hospice company is tasked with sending their resources out to still create a little bit of monetary gain. It's a business. So as a business, it's regulated under Medicare, and you have to come out at the end of the day with something.
You have to come, right.
It's more about that sometimes, and it's frustrating to families than it is about being with them. You're very limited to how much you can be with them. Hospice nurses don't come and stay all day. They just can't.
But and I think it's a general misconception,
Mm-hmm.
for sure. And you know, what we saw on this case was, you know, with 2 times a week nurse visits, you know, his last few days, the decline was rapid.
Mm-hmm.
And so a lot had happened between visit, you know, 1 that week and the second visit. And what, you know, he had that point because he didn't have anyone living with him. We had moved him into a skilled nursing facility, and he used his respite benefit through hospice, which was really a great thing. So he had 5 days, almost 4 nights inside of a nursing facility that was part of the hospice benefit that didn't need to come out of his pocket. And then we were able to coordinate with him for him to stay on, and he was then private pay and had round-the-clock nursing care. But something happened there where the nurses were giving him his hospice medications on demand, where he shifted between the nurses' visits, where he no longer was able to request the medications. And you know, we had a rotation of visitors, you know, between me and you know, some of his close friends and his pastor. But you know, we would arrive and he would say, I'm in pain. So you know, we hit the nurses' station, but there needed to be this transition where he no longer asked for his medications. They were delivered regularly to him.
Right.
So that was a little bit of a crunch that we ran into. And I think that very often between the patient and family, the facility and the hospice, there is just a lot of moving pieces.
There's some gaps right there. You know, you've identified the staff in the nursing home were as good as they could do, but they're just gonna set the tray of food down in front of you, and if you don't eat, they don't have time to adjust what they're doing, and they have to wait for a doctor's order even to do that, to say, okay, now I need to feed this person. You have to wait for somebody to observe that, report that, write an order, and change their dietary care plan.
Right.
And the same with the medication. So the hospice nurse visiting once every 4, 5, 6 days towards the change there had to come and observe that change, that he was no longer able to advocate for himself, and that they needed to update the orders to a scheduled medication.
Right.
But without seeing him as frequently, they didn't know that he'd had that change and that he was unable to speak.
And that's a true hospice limit.
It is a limit. They can't be there every day and check on that person and spend the really what could be better, that amount of time. So thankfully, one of the things you can do is stand in the gap for those folks and advocate for those folks in your role, and I'm glad you did for this particular patient.
Yes. No, I think that was a real blessing that I was able to, you know, because I want to get to this point, is that how did my client get me on as a person that could call hospice in between the visits and say, this is what I've observed.
Right, because
what
you're
are we
not
gonna
the
do
POA.
about this?
You're not medical POA.
Right.
You're not the general power of attorney. You're none of those things. You're Laurel.
Right.
So we had to go through and get him to sign.
The hospice, sure, they knew I was his end-of-life doula because he told them, but that doesn't automatically make me a part of his case with hospice care. And so I think that's something that is really important for families to understand if they want their doula to be a representative and an advocate during hospice care. So what did my client do so that I could now be a part and talk with you and talk with the social worker and you know, get his respite care set up? Otherwise, my hands were tied.
Absolutely, and again, that was another reason I stayed more engaged in this particular case, even though that wasn't my scope of service. But being able to talk with you a little bit around the edges of the case, I was able to realize what was going on and that you weren't getting the information, or David wasn't here.
Right.
And be able to have the patient to sign off on a HIPAA disclosure and amend his care plan, and it took a day or two, maybe, to get his signature on the ability to have you share information. I think what happens with hospice too is that it's so driven by that care plan, and that care plan has to have one point of contact for a lot of reasons, just for ease of communication, and that one person is supposed to, you know, disseminate the information amongst all the providers on the other side. It's a big challenge, so I had to amend the document to include 4 people, including you, so.
Right, no, and it made a big difference.
It did.
It really made a big difference. Now, not every family or, you know, dying person is going to experience, you know, that they don't have a caregiver that's part of their family, right? So some of these hurdles will not be as dramatic, but you know, if you read statistics, the amount of single people is actually really, really high, and particularly in the aging category. And so there's, you know, a third of those numbers, I believe, and it's in the, you know, millions of people are single and they're older age. And a lot of that is, you know, due to widowhood or divorce, or some people never married. A lot of people in the baby boomer generation do not have children, or maybe their adult children live on the other side of the United States, or maybe even they live abroad. And so having a doula that is able to, you know, be a point of contact, to stand in the gap in hospice care is essential.
It really is. I heard an interesting term on Tuesday at the senior center. One of the presenters said kinless, you know? It just kind of covers a broad spectrum of people that are kinless. They don't have, you know, someone they can claim as kin. But that's, again, to your point, where people need to understand what resources that they could access and potentially pay for, if need be.
Right. So I want to clarify too, you know, like what exactly is an end-of-life doula, right? If hospice is limited and a doula is going to come in when there is no family, do we need anybody else, right? Yes. This client, you know, like I said, he had to eventually be in a skilled nursing facility because he, you know, lived alone. You can continue though care under hospice in your home, and have, you know, caregivers. And so my role as a doula was not to be a caregiver on rotation. It was, I was the facilitator, and I was really the eyes and the ears for my client that you know was losing that ability to do so. At the very first of his days in hospice, he was able to make decision and to, you know, report back to me, well, hospice was here today, and you know, they're going to come back. But you know, that didn't last very long. And so, but you know, my job as a doula is not to be the caregiver. That doesn't mean that I will not, you know, I've walked into a scene many times and needed to help get someone cleaned up, you know, and to help them. But that is not that's not, you know, the full scope of my role. And I think that if I were to just focus on that, I wouldn't be able to be the eyes and ears and the advocate. So caregivers, you know, have a really large burden in the sense that oftentimes they're trying to do all of those things together. And you know, a doula can really lighten that load. And you know, in this case, you know, had there been a spouse or an adult child, we really want that person or those people to, you know, fulfill their vocation of spouse, you know, or child, or a friend, and be able to sit there with that person and not constantly be worried about, you know, did I talk to hospice? Do I know when they're coming? Did I do this? You know, when was the last time we gave medication? You know, let a doula, you know, do some of those, you know, those tasks. It can really just lighten the burden so you can be with the person who's dying.
I think that's important as well. Are doulas RNs? Are some of them RNs?
Great question.
Talk to me about that.
You know, no, I mean, I do have a few doulas training with me that are nurses, and it's really interesting. They don't really want to do that level of nursing care anymore. They've been serving people for a long time. Maybe they're, you know, kind of just making a career shift. They still want to be with patients. They particularly love the end of life phase. And so they're transitioning out of nursing care into the doula role. And you know, one thing that's important is that if a family hires a doula who also has their nursing license, that's 2 different contracts of work. So you're hiring a doula, and if it just so happens they also still have their nurse's license, you know, you can contract with them for other care as well. That's between that particular doula and the family. But you don't need any medical knowledge to be a trained doula. came from a household that my father was a physician, so I grew up around medicine. I grew up visiting the emergency room frequently. But really, I loved biology, but I don't have any real medical training or skill. And the doula role itself is non-medical, so I can't even give the hospice medications. I'm familiar with what they are,
Right.
and I understand how hospice has taught families how to administer the medications, and I can support the family in that.
Right.
Or whether it's a family member, or in this client's case, he didn't have family. He had his executor's wife was a nurse, and when he was still at home before the skilled nursing, she was administering those medications, right? So we can always find someone who can do that,
Okay.
but supporting that person, that is a really big job, to be the person who's administering the medication. It can produce some tension, and so being supportive in as a doula, helping that caregiver, whoever is listed as that person, making sure that the medications have been picked up from the pharmacy. That's what a lot of people find as a surprise as well, is that, okay, well, hospice is going to order the medications, but they're not going to deliver them.
Hospice is not allowed to do the delivery anymore. It used to be that way, 20 years ago they would have comfort kits in their car, but again, oversight and regulation and common sense says let's not keep meds in our car like that, at this day and age. But I think it's smart to talk about the limitations of providing hospice care in a facility versus home setting too, because as a family caregiver, you're limited what you can and can't do when you're in a facility. So even though your friend's caregiver was a nurse, she could not come to the facility and administer medications in a facility. Even though by her own, regulatory, she could, but different settings have different rules as well, and people don't understand that.
Right.
It doesn't, make common sense to people sometimes.
Yeah.
And everyone is trying to fulfill the letter of their obligation, but not always the idea behind it and the love behind it. You're kind of limited.
And as I think about what we've talked about today, end of life care is cumbersome. It's very cumbersome.
It's a little clunky.
It is clunky. And so the value of a doula is that they are, in their training, really understand the end of life process. They understand what's going to go on with hospice. Where are the gaps?
Yeah.
What is the burden of being a caregiver? What is the burden of being the dying patient, right? Spiritually, physically, a doula is really well-rounded because they get it all. And so they're able to kind of help navigate this clunky, cumbersome event of death. And it shouldn't be clunky and cumbersome.
I wish it weren't.
But at this point it is. And I do believe that the wider industry, not just hospice care, not just funeral directors, not just hospital administrative staff and doctors, there is a movement to make things better. And doulas are a vital part of the movement.
There's definitely a movement, a death positive movement. We've talked about this before, and hospice is understanding that. They do understand there are advocates out there. There's a bill in front of Congress right now. There have been several proposed through national hospice and palliative care organizations to expand the hospice benefit to address some of the gaps that we've been talking about. But as of right now, it takes money. It's a government entity. It takes money. It takes time. There is a palliative care movement too, but it doesn't always really reach the folks that it needs to reach, and it's not nearly as comprehensive as it could or should be. But people are recognizing that they need to have more conversations around how to have a peaceful death, how to have an attended, Christian, loving passing. And that is just something that I think the pendulum is swinging.
It is swinging.
It is swinging. Yeah. It's just taken a while. And there's not an easy answer for that.
Well, culturally, we've been disconnected a bit from what our hope is around death. And our hope is that, we will live again, right? We'll have new bodies and we'll live again. And even in our churches, we're a bit disconnected. We have different ideas of heaven and the afterlife. And so, really, this great movement of simplifying end-of-life care and making it available to everyone and helping families navigate it, and particularly those who are going to be survivors, who navigate their grief, and that bringing faith into that is essential, and bringing faith into medicine is essential. And trained Christian end-of-life doulas, if they are requested not to speak of their faith, they won't, but they will serve from their faith. And those that, hire doulas that do want a Christian at their side. And that's been a bulk of my cases, that I've really been hired for my knowledge of the end-of-life experience, but also for my faith. And so having a Christian, walk alongside with you is invaluable.
I think that's so crucial, especially sometimes people are disenfranchised from their churches. Maybe their parish leader is not trained to go be bedside. I know many are. We're fortunate in that. But there's definitely that missing from our culture.
It is missing, and oftentimes, I've worked in many churches, is that, even if the desire is there by the clergy, the time's not there, right? They may be a single pastor with, a growing parish, and there's so many demands. Mm-hmm. And so a doula will never replace a pastor, although the role is pastoral. And I do find too that I'm often the one who connects the dying person with their church community. And I think it's very common. Someone gets an illness, they stop going to church. People are like, well, what happened to, that person? And then people don't really know how to react and how to engage. Well, I want to call them, but I don't know what to say, right? And so I found actually probably what I enjoy most about the work is engaging communities with the situation and having them come, if the dying person wants it, to be a part of their end of life. And that can change the future for church communities.
Mm-hmm. Mm-hmm. I think it's also important, and this is probably my last topic, but I have to get on my soapbox. The month of April, Advanced Care Planning Month, Advanced Care Directives Day, April 16th. Open up the conversation. People you care about, family, friends, have you talked about what you want, what your wishes are, what kind of care you want in the event you're not able to speak for yourself. Let people know your wishes. Make some plans. Just because you talk about it doesn't mean that it's going to happen tomorrow, but it is going to happen, and we want to be there as healthcare professionals, and we want to do what it is that you want. So please do yourselves and your family the honor of talking about these difficult things, about your plans, your wishes, your goals. If you want a feeding tube, if you want artificial hydration, nutrition, if you want intubation or not, we need to know from a healthcare standpoint so that we can help you chart your course and keep you as happy and comfortable and peaceful as you want to be.
Yes.
Yeah.
Yeah, thank you, Kate.
Thank you.
I enjoyed having you not just, I should say enjoyed having you be a part of that case with me, but it made a huge difference for me as a doula. And so I'm glad that we've been able to extend beyond just that period and look at how we can continue our work together for our community.
There's so much more.
Yes.
We'll talk again.
Yes, awesome.
Yeah.
Thank you.